Ladies and gents, so what is heart failure? Contrary to common misconception, heart failure isn't the concept whereby the heart is slowing down from its usual pumping mechanism of 72 beats per minute in the average healthy adult human being, reducing in number to a grinding halt so that it comes to a standstill. That's not heart failure. Heart failure essentially is more so to do with a reduced efficacy with which the heart actually pumps. Okay, so just to remind us that the heart is nothing but a pump. It's a muscular pump, one of three muscles in the body, which is this one is the cardiac muscle, and the heart is made up of cardiac myocytes or cardiomyocytes. These muscles, these cells have the inherent ability to be able to generate electrical impulses without any external influence, meaning that they are myogenic, i.e. self-initiating. They're independent of nervous impulses. So you can actually take out the heart from someone's body, place it on the table, and it'll continue to beat. This is due to the phenomenon known as automaticity. Okay. Now the heart itself, what happens in heart failure is that it becomes overstretched. Okay, the heart muscle becomes overstretched beyond its limit that it should otherwise physiologically be. When the heart cardiomyocytes become overstretched, they release a peptide hormone known as proBNP or BNP. That is what we measure in someone's blood test, the levels of which, if they are escalated or elevated rather, then we are suspecting or diagnosing heart failure. How does the fact that the heart muscle is overstretched affect its ability to pump? Well, if we consider we've got the four chambers, two at the top known as the atria, and then the two thicker ones at the bottom known as the ventricles. The left ventricle is the one that has the thickest muscular wall. Why? Because the left ventricle pumps blood all the way around the body. So a thicker wall means that it's going to have sufficient ability to be able to generate sufficient pressure, the contractile force to then in turn sufficient pressure to be able to pump the blood all the way around the body via the aorta, the largest blood vessel in the body. Now, if that heart muscle is overstretched, then the muscle is essentially that little bit looser, and so the force of contraction that it then generates is reduced, and because the force of contraction is reduced, in turn the pressure that's then exerted on the blood is therefore in turn also reduced. Now this has an impact. What impact does this have? Well, this has an impact on what we call venous return. So one of the classic signs and symptoms of, and please be aware this is not the only cause of the said symptom which is increased swelling around the ankles and the lower legs. Like I said, this is not the only cause of swelling in the ankles, so please don't be taking this in isolation. One of the other signs is distended JVP, which a clinician can measure or otherwise increasing shortness of breath on exertion, and that's because we get what we call pulmonary edema or pulmonary congestion, because the fluid then backlogs into the lungs. And these are because, don't forget, the heart is a double pump mechanism, and you can have either right-sided heart failure, otherwise also referred to sometimes as cor pulmonale, or left-sided heart failure. And the most common cause of right-sided heart failure is left-sided heart failure, because then we get the backlog. So the pump mechanism is not as efficient, so the water then backlogs, and that's how we then get the classical features of the said issue. So how do we then go about managing this? Well, we need to, one of the most common examples or causes of heart failure essentially is myocardial infarction, i.e. heart attack. So infarction means death of muscle. Remember, when we look at myocardial infarction, the certain area of the heart is what's affected, okay? Certain area of the muscle that's damaged, and so if that muscle undergoes infarction, i.e. death, it's no longer going to be able to contract. So inability to contract means inefficacy of the heart pumping mechanism. So what we do in the said situation is, when a patient undergoes an MI, myocardial infarction. One of the prognostic markers and one of the tests that we do later, not immediately, the point of care testing is the ECG, chest X-ray, everything else to make the diagnosis and ascertain which region of the heart is affected. That's a separate entity altogether. But later what we do, aside from the angiography, which is what most people are familiar with, this is whereby they insert the contrast dye, be it from the radial artery or from the femoral artery, and you get a bit of an image, a kind of an X-ray image, as I would refer to it otherwise, of the coronary arteries, the arteries which supply the heart itself with the blood. So aside from that, what we will do is what we call an echocardiograph, and that is essentially an ultrasound of the heart coming in from different angles, usually 3. And amongst many other things, there are 3 key features that we are measuring in the context of heart failure, because MI, like I said, the heart attack will damage that certain area of the muscle, that regional wall that's affected, and then that area will undergo in the long term is failed. So one of the measurements is what we're looking for is regional wall motion abnormality, RWMA. The second we measure is the left ventricular systolic dysfunction. So remember I said to you a moment ago, the left ventricle is the thickest ventricle, the thickest wall. And so we're looking at the systolic function of that. Systole means to contract. So we're looking at how efficiently or how effectively that wall is contracting. And so that's your LVSD. And that closely follows the next measurement, which is ejection fraction, the amount of blood that is being pumped out by that area on each contraction. So we measure that as a percentage. So these 3 are the key features we measure on an echocardiograph, amongst other things, including all the valves and everything else, but from prognostic standpoint in the context of heart failure, post-MI or otherwise. Please remember what I've said, don't take this in isolation. This is serious matters. If at all you have any concerns or queries, these are not diagnostic in isolation. This is purely for information purposes. If you find you have any concerns, please discuss that with your physician. Thank you for watching.